My topic will be from clinical trials to clinical practice, navigating management with CDK4/6 inhibitors. So we've seen how the first-line space has changed with the hormone-positive metastatic breast cancer. We started off with just tamoxifen, and we went on. We used to talk a PFS of 6 months. Then the AIs came in. We said 10 to 12 months. SERDs came in. We said a little better than that, but not too great. And then with CDK4/6 AI's first-line setting nowadays, we talk of a PFS of 24 to 28 months, and this is very consistent. We have seen how CDK4/6 came into play, understanding how the CDK4/6 with cyclin D1 is overexpressed in breast cancer, how the cyclin D1 is overexpressed in breast cancer, how the inhibition affects the G1S checkpoint, and how blocking this becomes very important. We are using this information for breast cancer for treatment, but I think if all of you have seen the recent new CDK4/6 inhibitor data, the data of trilaciclib, if you've seen this new IV CDK4/6 inhibitor, which we are using this information, the side effect information, for clinical practice. So just to talk about it, if you're using the drug called trilaciclib, which is approved by FDA, it is suppressing your blood counts during treatment. It's an IV CDK4/6. It suppresses your blood count. You give the chemo, and then the blood counts will recover after that. So you don't have neutropenia. So FDA approved it for preventing neutropenia. So we have a CDK4/6 now, IV, approved for preventing neutropenia. It is approved in small cell lung cancer with carboplatin etoposide in the first-line setting. So see, this is how the science changes, You learned about CDK4/6, you learned cyclin D1, you used it in practice for your breast cancer cells, and now you're using that information of CD6 inhibition and using it to prevent neutropenia in cancers. So amazing way the science is changing, and this is how we keep learning new things, and that's the way we move forward. So first-line therapy, I think we've heard that excellent panel discussion. Let me just run through data sets just quickly, and then we'll just, I'll probably just conclude it putting it all into a summary. We saw the first data, palbociclib letrozole. Palbociclib was the first CDK4/6 inhibitor which came into the market. The data sets of Paloma-2 was using as first-line data, and we saw how there was almost doubling of progression-free survival, 14.5 months going to 27.6 months, hazard of 0.56. And with this, the approval came in. I think 2016 October was when the drug got approved in India, and I think since then we have used this drug extensively. There's really no doubt about it. I recently, just last month, saw one of my second patients started on palbociclib letrozole. So she's 5.5 years down the line with metastatic setting. She's still containing palbociclib letrozole. So this is how you get so excited about, you start seeing this group of patients after years and years and years, and they do well on one line of therapy. So that's the way the data goes. We saw that every subgroup benefits, be it visceral disease or non-visceral disease, bone-only metastasis, treatment-free interval, anything you talk about, these patients benefit. And then the data came for MONALEESA-2. That was using ribociclib letrozole in the first-line setting. And again, it's very similar curves, 16 months going to 25 months, hazards of 0.56, bang on, exactly the same, similar curves. And then you saw the MONALEESA-2. This year, we saw the overall survival. So this time, this was very impressive. This is the first time we saw overall survival in the first-line setting. 51.4 months with ribociclib in the first-line setting, going to 63.9 months. So more than 1 year survival advantage in the overall survival. Now, one can look at this in different ways, trying to understand what was. So whenever you see OS data sets, always please look at what were the next line of therapies used. And that's very important to understand the overall survival. But it's so difficult to get overall survival in first-line setting. And this is the first trial to get it. So no doubt about it, MONALEESA-2, very impressive data sets, 1 year survival advantage. Again, if you see, all the subgroups benefited with overall survival. So really, there's no one where you'd say you'd prefer to use it. Everyone benefited when you added ribociclib with letrozole. The third drug, MONARCH-3 study using abemaciclib. And then again, here you see almost the same thing. You see the hazards, 0.54, 14.7 months going to 28.8 months with abemaciclib. And again, the benefit is exactly the same. All the subgroups have been seen, and especially in abemaciclib, you keep talking of high-risk disease. You keep saying visceral metastasis, liver metastasis. And again, you see the benefit is there and exactly the same. So we have these. Of course, we cannot disregard MONALEESA-7 because this is a very different trial done for the pre-menopausal population. And I think that takes a sort of an initiative to really take up a whole group of premenopausal women and treat them with ribociclib, with hormonal therapy, of course, using LHRH also in comparison. And again, we see the same kind of a progression-free survival, 13 months going to 23 months. Hazards are again 0.55. And we also saw the overall survival data, 48 months going to 58 months, which is statistically significant. And we heard this, Mona Lisa has all the overall survival data sets already. So if you put them all in perspective, I think the bang there is the PFS, and that's exactly 0.54, 0.55, 0.56. It's exactly the same in all the trials. But you have OS data of Mona Lisa 2 and Mona Lisa 7 in this setting. Does that mean this drug is very superior to the others, or the others are inferior to this? Absolutely no. I think with this kind of PFS, which you're seeing everywhere, you kind of think they're almost the same. I think the first-line trials, that's what they teach us, because these are very uniform population of patients. They're not like the second-line trials where you have different populations. Here, the population was very uniform. So all of them showing the same PFS, showing the same kind of a benefit. But yes, the OS data of Paloma 2 and Monarch 3 has still to mature. And I think with time, we will see as it matures what the data sets come out. So then the difficulty comes, how are we going to choose? And what are we going to do in choices? And that's difficult in every clinical practice. I think with every patient we sit in, we have all the three options and we end up saying, how are we going to choose between them? When we think in the first line setting, they are almost the same. I think it will come down to toxicity, and that's the most important factor. Palbociclib, ribociclib causing much more neutropenia, thrombocytopenia, but again, hardly any febrile neutropenia. With abemaciclib, we have already seen diarrhea is much more common, neutropenia is much lesser. These are kind of regimens we have learned to use with time, and as the new drugs come in, we start using it and we learn better how to use them. So I would say once we've used palbociclib, we are so comfortable with it for so many years, and then ribo came in, we introduced ribo, and now with abema, we are getting comfortable even with abema. So I think it comes down to toxicity, and as previously mentioned in the discussion, again, cost is a major issue. You eventually choose what your patient can pay from your pocket and be able to take it. But I think there are support programs for all three in India, and that's very good that most patients who can extend the treatment can carry on for years and years. That's the best thing about it. Dr. KP showed this, the Parsifal data. The question always comes, if we change the letrozole and move to fulvestrant first line with palbociclib, would that do better? And this was always debated because we always thought fulvestrant may be slightly better than using letrozole. But this data is very good because this information helps us in clinical practice. We can clearly say, no, letrozole, palbociclib, and fulvestrant are exactly the same. And this data is helping us choose and say, it's best to be on letrozole. I don't see any point in putting an IM injection for a patient for years. It's very, very difficult. I think fulvestrant is a very, very excellent drug, but very tough because of the IM injections which you start giving. We have patients on fulvestrant who have crossed many, many years, and it becomes more and more challenging. Patients will start complaining after the second year and third year that why don't you change to oral? And we don't have anything to change to. We say we have to give that IM injection. And you feel quite I would say it is difficult for the patient. An IM injection, both buttocks, goes on monthly. First month, they are very happy because their responses are good. They want to do it and they're very excited. Second year, they start getting a little bit annoyed. By third year, they're really annoyed. They say, this has to stop. This cannot go on. So we have a patient on fulvestrant now for 7 years, and she keeps telling us, this is crazy. How long are you going to keep doing this? And we say, we don't know what to change to. You move through all your chemo or hormonal lines, and this is the one which was working for you for years. We don't want to change it. But this is good data. I feel Parsifal answers that question. Letrozole palbociclib is the ideal first line, and we should stick to that. Another important question, we keep debating, what if we give chemo to our patients? And I'm not talking of patients in visceral crisis. We are saying patients in first line setting when you talk about if you have a patient. So we have data sets to answer, and this is we saw 2 data sets. We saw the Pearl study coming out where you use second line patients who had progressed on 1 line of hormonal, whether you want to go to capecitabine or whether you want to go to fulvestrant palbociclib. And what it taught us was actually there was no difference in the hazard ratio statistically. So it did not matter. You can actually go to fulvestrant palbociclib and keep the capecitabine as a reserve. And that's what this trial showed. But I think the more impressive one is the Young Pearl study, a very difficult and tricky study to do. This comes from China, but if you look at it, it's first-line setting. You use premenopausal patients and you do capecitabine versus ovarian suppression with exavestine and palbociclib as first-line therapy, trying to answer, is chemo better or is hormonal better? And this study was presented in ASCO 2019. So can you imagine, this study has been done in the last few years. Which patient of hormonal would you really give chemo at the present time in such big numbers? So that was very amazing to see. But the data set again is good for us to answer a question. It said that it's better to do palbociclib exemestane with LHRH rather than doing capecitabine first line, and the hazards were statistically significant. 12 months versus 14.4 versus 20 months. So again, we got an answer here. Whenever we say if patient is not in visceral crisis, should we give chemo? I think Young Pearl is teaching us better to avoid chemo and just stick to hormonal therapy with CDK4/6 inhibition. So moving on to second line therapy, second line space is much more complicated space because all the three trials have very different inclusion populations. They're not all the same, and that's why you kind of can't just compare these three trials together. So first was, if you look at hazards again, you'll see PFS hazards are exactly the same, 0.55, 0.59, 0.50 with all the three drugs. But if you start seeing OS hazards, they're different. And that's why one needs to really look into the depth of data, why the OS is different. It's not that one drug is very superior than the other, but we are learning differences. So first is Paloma 3. We saw the overall survival, which was published. Now, if you looked at it, even though you kind of think the hazard was 0.79, it did not meet the statistical boundary. So that's the reason it was not significant. But when they looked at patients who were hormone sensitive and patients who were without sensitivity, when they removed that, we clearly saw the patients who are hormone sensitive, the benefit is there in overall survival with a hazard of 0.721, 29.7 going to 39.7. And if you saw the non-sensitive patients, there was no benefit in the overall survival. So again, it is giving us an indication where we think of using palbociclib in the hormone-sensitive relapse setting. Again, this trial also had patients who had received one line of chemotherapy, which is quite different from the other trials. We saw the Monarch 2 data from abemaciclib, and here again, we see very interesting data. The overall survival moving from 37 to 46.7 months, hazards of 0.75. But when you divided them into the primary resistant and the secondary resistant subgroup, here's where you see abema scoring over it. In primary resistant group, your hazard of 0.68, telling you this drug is working even in this primary resistant group setting, 31 to 38 months approximately, but the hazards were significant. Now, in the secondary resistance, you don't see a difference yet, but I think that's because you've not had enough events here, because the secondary resistant population really does very well in the long term. So probably the events have not happened yet. But again, clearly a very beneficial drug in this population. And of course, we saw the Mona Lisa 3 data. Again, the same PFS benefits, but the overall survival, 40 months versus not reached, hazards of 0.724 was statistically significant. So clearly showing again, this is beneficial in terms of overall survival also in this group of population. So second line is a very is a different space where we kind of start looking at sensitivity and resistance. If we have primary resistance, a lot of talk is going towards using abemaciclib much more, though there is equally good ribociclib data. Palbociclib is being sort of reserved more in the second line setting for sensitive patients because of the way the overall survival data came out. But again, are this data different due to the design of clinical trials or due to the drugs are different? This is something we'll keep evaluating as time goes. Now, towards the end, I just want to talk about a little bit of the real world experience. We saw the Flatiron data from the palbociclib trials. This was a huge data set where they again did just the patient groups, but then later they did a propensity score matching where they tried to match both the patient groups. And here they saw PFS benefit again in the real world setting, hazards of 0.54, exactly the same. And the overall survival benefit, again, 0.58 hazards. So it was significant here in even terms of overall survival in the real world setting with this kind of statistical analysis. There was Indian data of palbociclib, and this is data coming from Dr. Chaturbhuj Agarwal from Delhi. Again, the big data set, 188 patients treated. And what you see is almost the same PFS, what you saw from all the international trials. Median PFS 20.2 months in the first line setting, 12 months in the second line setting, very good impressive response rates of 80%, and again toxicity being very less, which clearly is what what everyone has seen from the trials also. There was data from many of centers in South India. There was pooled data looking at 5 centers from South India, and this was an initiative done where all 5 centers collated some amount of data and analyzed this. This is an interesting data set again. 133 patients were treated, and again, when we divided them into a first-line setting, what we saw was first-line settings again doing very well. It's a second-line setting. We had a median PFS of 14 months, though there were some second-line patients who had actually received chemo and then gone on to second-line setting. Again, in the first-line setting, de novo patients really did well compared to the relapsed patients. And again, bone mets patients did really well compared to visceral mets. We saw neutropenia in more than 75% of patients, but there was no febrile neutropenia, and that's what makes us very confident of use. So I would like to leave you with this thought. This is where the future is going. We've talked of CDK4/6 with AIs as first line, and that's become standard of care. There is a thought that if you did a SERD, and a SERD may be better than a SERM. So the thought is, if there's a SERD which you can give comfortably, which is not IM, which your patients can take very comfortably, and that's where the oral SERDs are coming in. And you can see 3 new oral SERDs: amcinestrant, giredestrant, and camizestrant. They're going to be much more complicated for us in future. I'm sure in the next 2 years, we'll be debating which of these SERDs is better, just like we were debating which of the CDK4/6 are better. So this trial is looking at amcinestrant plus palbociclib versus palbociclib-letrozole. So you're moving your trials to a next level, and this is how it's going to change. I'm sure, look at the size of the trial, 1,066 patients, and it's going to be stratified to everything. It started off also, and we have already seen the amcinestrant data through the Emerald study already in the last year, San Antonio, where it was, I would say, slightly better than fulvestrant in the second line setting. So we have thought maybe it will be a better drug, and let's see how the future goes. So this is how I end. CDK4/6 has changed our clinical practice. We've seen rapid and durable responses. We are very, very confident of using it. We don't offer chemo to any patient. Visceral crisis can be a little bit controversial, and that definition is also changing and evolving. The best thing is we don't get chemo side effects. We have one long duration of therapy on one line, and that matters to patients. We really don't want to keep telling your patients, after 6 months, 1 year, no next progress, now we will use the drug. You want to put it up front where they can continue on one drug as long as possible. Our quality of life is excellent. And now we are starting to see the overall survival data sets. And that's, again, very impressive. Thank you very much.